your clinical instruction. And today, I will be performing nasogastric tube insertion, administering feedings via nasogastric tube, and removing nasogastric tube. First, the nasogastric tube insertion. This procedure refers to the insertion of a tube through one side of the nose, passing through the nasopharynx into the esophagus, and finally into the stomach. The purposes of this procedure are as follows. 1. To establish a method for draining the stomach or the intestines, to intervene in pre-existing or impending nutritional depletion from debilitation, for diagnostic procedures or purposes, to provide means of nutrition if there is an inability to swallow or an existing obstruction in the alimentary canal, to provide nutrients for client in comatose or semi-comatose state, to decompress the stomach before and after surgery, to provide nutrients for post-operative clients with bowel sounds present, and to maintain fluid and electrolytes. The following are the equipments needed for this procedure. The nasogastric tube or nasointestinal small bore feeding tube, your water-soluble lubricant, your ice chip or a glass of water with straw, your pH test strip, an appropriate sized syringe, your sterile gloves, your 1-inch tape, washcloth, your gauze, cotton balls or cotton tip swab, your emesis basin, and your tissue. So first is to perform hand hygiene and organize your equipment. Hand hygiene will reduce microorganisms transfer and promote efficiency of the procedure. Next is to explain the procedure to the patient and secure consent. This will help reduce anxiety as well as promote cooperation and participation. NGT insertion is an invasive procedure requiring informed consent. Ngayong aga, sir. Kung dali, sir, matakot kita sa tubo, habi sa iyong mga ilong para makakaon ka kag makahatag ka sa mesong ilong. Next is to place the patient in semi-collar's position. This will facilitate passage of tube into the esophagus instead of trachea. Next is to check nasal patency. Ask the patient to breathe through one nares while other is occluded. This will help determine patency of nasal passages. Sir, ginhawa ka sir, nga nakatabon ang isa mo ka ilong. So, you ask the patient to breathe through one nares. And you also feel if there is an air coming out from one nares. And you do the other side of the nares. Sige sir, ginhawa sir. And have client blow nose with both nares open. Clean mucus secretions from nares with moist tissue. So sir, mag-blow kita with both nares open. And wipe if there is mucus excretion coming out from the nose. The next step is to don gloves. This is to reduce the risk of infection transmission. And use water-soluble lubricant or deep feeding tube in water to lubricate tip of sternal notch. Mark the location on tubing with a small piece of tape. So you have to assess the quality of the tube. If it is too soft, you can dip it in cold water to make it stiff. If it is too stiff, you can dip it in warm water to soften it. Then, measure the length of tubing needed by using tube and measure distance from tip of the nose to earlobe and from earlobe to sternal notch. Mark the location of tubing with a small tape. So, today, our nasogastric tube has already markings. So, if there are already markings, you do not have to use a small tape anymore. So, you have to measure from the tip of the nose to the earlobe, tip of the nose to the earlobe, and from the earlobe to the sternal notch. And mark your measurement. Make sure to maintain the sterility of the tube. So as you can see that the tube has already markings. So there's no need for you to place a small tape anymore. So if the tube feeding with weighted dip is used, measure from distance as instructed in the package, and insert guide wire and prepare the tube as instructed in the package. An improperly positioned stylet or guide wire can traumatize the nasopharynx, esophagus, and stomach. Then, ask the client to tilt head backward and insert the tube into the clear nares. This will facilitate smooth entrance of tube into the nares. Sir, medyo tanga gamay sir ha. As tube is advanced, have the client to hold head and neck straight and open mouth. So when the client is opening the mouth, check if the tube is already the esophagus. So when tube is seen and client can feel the tube in pharynx, instruct the client to swallow, or you can offer ice chips or sips of water unless contraindicated. This will facilitate passage of tube into the esophagus. Sir, tulun sir. Sige pa sir, tulun lang. Tulun sir, tulun na kalaway. Sige sir, sige pa, tulun pa. Continue to advance the tube further into the esophagus as client swallows. If client coughs or tube curls in throat, withdraw tube to pharynx and repeat attempts. Between attempts, encourage the client to breathe deeply. This will help prevent trauma from forcing tube and prevents tube from entering the trachea and maintains oxygenation. So when the tape mark where your mark of the tube reaches entrance of nares, stop tube insertion and check placement by the following procedures. So have the client open mouth to facilitate visualization. So sir, paki-open na sa mouth sir, so you can check if the tube is in the mouth or not. So also, um, another way to check if the tube is already placed in the esophagus is to aspirate with syringe, noting the color of secretion return and checking pH of drainage. So the pH between 1 to 4 may indicate gastric secretions, while pH of 6 or higher may indicate intestinal placement. So you can aspirate the gastric contents using your aseptal syringe. Another method is by aspirating with syringe, noting the color of secretion return, and checking the pH of drainage. A pH between 1 to 4 may indicate gastric secretions, while pH of 6 or higher may indicate intestinal placement. If fluid is removed, the assumption is that the tube is in the stomach. Stomach contents may be yellow with mucus or clear. So after aspirating the stomach content, we can now check the pH of the content. 3, 3. So the pH is 3. Therefore, we can say that what we have aspirated is a gastric secretion. Another is to inject 5 to 10 ml of air into the tube while simultaneously auscultating the epigastrium with stethoscope. A popping or gurgling sound is heard when the tube is in the stomach. So we have to inject 5 to 10 ml of air and look for a popping or gurgling sound. This is the most common way of checking the placement of our
Ha?
nasogastric tube, since
Pwede na
the
natin sa
HPF
laptop.
strip may not be available in all facilities. And the last way to check the placement of our NGP is by X-ray confirmation. If nasoduodenal or nasojejunal feedings are required, clients should have an X-ray to confirm correct placement.
Kagano binang extension?
So
Sige.
after checking the placement of our NGP, we have to secure tube by attaching the virtually prepared tube holder or by the following procedure. 1. Splitting 2 inches of strip of long tape, leaving 1 inch of strip intact. This will maintain tube placement with client's splitting. So we have to close first the tip of the NGP. We have to secure first the placement of the NGP in the nose of our patient. So we will use this adhesive tape, split into two. We have to make sure that it is secured as neatly as possible, for also to promote the comfort of our patient. We can also apply 1 inch base of tape on the bridge of the nose, like what we did. Taping in this manner prevents the tube from pressing against and irritating the edge of the nose tail. And wrapping first one and then the other side with tape around the tube, as just what we did earlier. Next, we have to clamp or plug the tube tightly. This will prevent passage of air into the stomach and leakage of stomach contents from the tube. So, as you can see, we should not leave the end of the tube open. So, there are some tubes that has already a stopper, but in this case, since it is open, we can just um, clip uh, a portion of the tube and insert it. And attach the end of the tube to the gown of the patient by one of these following two methods. One, loop an elastic band around the end of the tubing and attach an elastic band to the gown with a safety pin. This will decrease flow of client's nose and possible dislodgement. Or we can attach a piece of adhesive tape to the tube and pin the tape to the gown. So we cannot let this tube hang in the patient. So we can just arrange it in a way that it will lessen the possibility of the clients pulling this tube. So we can, and you can clip it in the patient's gown. So after that, our NCT insertion is already done. We can now discard our used equipment and perform hand hygiene to remove microorganisms in our hands. And of course, we have to document data to provide record of the procedure as performed. So that ends the nasogastric tube insertion. The next procedure is administering tube feeding. So this procedure refers to the introduction of liquid nutrition into the upper gastrointestinal tract by means of a tube. Tube feedings are delivered by a nasogastric, nasointestinal, or trans-abdominal tube. So the purposes of this procedure are the following. First, to to restore or maintain nutritional status of the patient and to administer any medication. So we will be needing the following equipment: our stethoscopes, pH paper, a septic syringe, washcloth or towel, our medications to be administered, our tube feeding as ordered by our physician, non-sterile gloves, and a cup or glass of water. First in the step is to determine the type, amount, and frequency of feedings by checking the doctor's order. A physician's order is required for enteral feedings. Rate and frequency of feeding are crucial for providing adequate nutrition for the patient. Next is we have to assemble our equipment needed. This will help promote the readiness of feeding for the administration. Next is to assist the client into semi-fowlers or fowlers in bed or in a sitting position in a chair. The normal position is sitting. If in a sitting position or if a sitting position is contraindicated, a slightly elevated right lying position is acceptable. This position enhances the gravitational flow of the solution and prevents aspiration of fluid into the tubing. Next is we have to explain to the client what are we going to do, why it is necessary, and how the client can participate and can cooperate to the procedure. Inform the client that feeding should not cause any discomfort but may cause feeling of fullness. This will help reduce anxiety as well as promote patient's cooperation. So sir, good morning. So subong sir, mahatag ko sa feeding sa imo. Ipaagi ko lang dire sa imo nga nasogastric tube. Kag mahatag man ako sa imo nga gulong, ipaagi ko man gyapon sa nasogastric tube para hindi ka magutuman sir. Next is we will have to wash hands and observe infection control procedures. This will reduce transmission of microorganisms. After performing hand washing, I will now wear my clean gloves. Next, we have to provide privacy for the client. Since nasogastric and nasoenteric feedings may be embarrassing for other people. Then we have to place towel on client's chest to prevent spoilage of the bed linen and gown. Then we have to assess the tube placement. We have to attach the syringe to the open end of the tube and aspirate alimentary secretions. We have to check again for the pH and allow 1 hour to lapse before testing the pH if the patient received a medication. Stomach contents normally measure a pH of 1 to 4 and intestinal contents have a pH of 6 or greater. So we have to aspirate the stomach content and again check for the pH. So we can use a pH meter rather than pH paper if the client is receiving continuous feeding or if food coloring has been added to the formula. Then we have to assess the residual feeding contents. So we can aspirate all the stomach contents and measure amount before administering any feeding. So after taking the pH of the gastric content, we can aspirate the total contents or all of the contents of the stomach. So we have to aspirate all the contents in the stomach. So if 100 ml or more than half of the last feeding is withdrawn, check with the nurse in charge or refer to the agency policy before proceeding. The precise amount is usually determined by the physician's order or by agency policy. At some agencies, a feeding is withheld when a specific amount or more of the formula remains in the stomach. In other agencies, the amount withdrawn is subtracted from the total feeding volume, less the digested portion is administered slowly. So, if you have withdrawn 100 ml or more, you have to check with your agency policy whether or not to withhold the next feeding or to delay the next feeding. Next, after which, we have to reinstill the gastric content in the stomach if this is an agency policy or a physician's order. So, after aspirating all the stomach content, check for your agency policy. Perhaps your agency policy states that you have to instill whatever you have aspirated so you can return it to the stomach of the patient. Next is to administer the feeding. So, check for the expiration date of the feeding. Warm the feeding to room temperature, since cold feedings might irritate the gastric mucosa of your patient and may cause cramps. So, when an open system is used, clean the top of the feeding container with alcohol before opening it. This will minimize the risk of contaminants entering the feeding syringe or the feeding bag. So, we have now to administer your feeding. So, you have to check the doctor's order if how many ml should be served per feeding. So, supposing that this is a this amount is indicated in your doctor's order. So we have to attach again our efficacy. So you make sure that um, when opening the end of your nasogastric tube, you have to pin it so that this will prevent the air from entering the tube. So remove the plunger from the syringe and connect the syringe to a pinch clamp or nasogastric tube. Pinching the clamp to prevent pinching or clamping the tube prevents excess air from entering the tube and causing stomach distension. Next is to add the feeding to the syringe barrel to facilitate administration of the feeding. So you have to open, make sure that the tube is still clamped, and you have to place the feeding in the opening of your feeding. So permit the feeding to flow in slowly at the prescribed rate and raise or lower the syringe to adjust the flow as needed. Quickly administered feedings can cause flatulence, cramps, and reflux vomiting. So, as As you can see, the higher the height of the tubing, the flow of the feeding is faster. If you're gonna lower the height of the feeding to the patient, it causes slow movement of the feeding in the tube. So you have to raise the tube if you want a faster feeding. So administer. So after all the feeding has been administered, we can now rinse the feeding tube immediately before the formula has run through the tubing. So we have to instill 50 to 100 ml of water through the tube and prevent blockage by stiff formula. So we have to instill 50 to 100 ml of water. So after the tube has been cleared by water, we can now clamp and cover the feeding tube. So we can clamp the feeding tube before all water is instilled. Clamping prevents leakage of air from entering the tube. This is done before all of the water is instilled. And cover the end of the tube with gauze held by an elastic band. Covering the tube prevents leakage from it. So since the tube has no built-in cover, so we can just pin a portion of the tube and insert it to the opening end. And then ensure client's comfort and safety. So pin the tubing back into the client's gown. This will minimize pulling the tube, thus preventing discomfort and dislodgement. So we can arrange it back again to its original place. And we can pin it around the client's gown. Then ask the client to remain sitting upright in tallest position or in slightly elevated right lateral position for at least 30 minutes. These positions facilitate digestion and movement of feeding from the stomach along the alimentary tract and prevent the potential aspiration of feeding into the lungs. These measures also prevent irritation and erosion of the pharyngeal and esophageal mucous membranes. Then, check the agency policy on the frequency of changing the nasogastric tube and the use of smaller lumen tube if a large bore tube is in placement. So, some agencies may require nasogastric tube changing every 7 days or every 14 days or as soon as um, the tube is already clogged. Then we have to do aftercare of the equipment. If the equipment is to be reused, we can wash it thoroughly with soap and water to prevent transmission of microorganisms and help prepare for the next use. And we can do our hand washing to deter the spread of microorganisms. And do not forget to document relevant information to provide with record for future reference. So that ends our feeding via nasogastric tube. Our last procedure is the removing of a nasogastric tube. This refers to the removal of the nasogastric tube once the reason for the nasogastric tube insertion has been resolved and the physician orders the tube to be removed. The purposes are the following: to facilitate the removal of the NGP when it is no longer needed, and to apply basic skills in physical assessment for the presence of vowel sounds. These are our equipment to be needed: tissue paper, clean gloves, kidney basin, plastic bag will serve as our waste receptacle, mouthwash, and towel. So first, we have to assemble all the equipment needed to promote efficiency of the procedure. Then confirm the physician's order to remove the tube. Removal of NGT necessitates a doctor's order. Then we have to assist our client into a sitting position if health permits. This will prevent regurgitation and aspiration since the cardiac sphincter is relaxed by the presence of the tube. So sir, matungko kita kay buksan ka na ang imong nga tubo sa ilong. Then we have to place the disposable pad across the client's chest to collect any spillage of mucus and gastric secretions from the tube. This will prevent soilage of the patient's gown. Then, provide tissue to the client. So, sir, ari ang tissue, sir, ha? Kung may magawas karon sa ilong mo, pwede mo gamiton kag trapuhan ang imong nga ilong. Then, explain the procedure to the client. This will help promote cooperation and reduce anxiety. So, sir, tanggalin ka na ang inyong tubo kung hindi mo na siya kinahanglan. But pwede mo na kaya mo na magkaon paagi sa inyong nga baka. Kag naghambal sa doc nga pwede na iluksin ang inyong nga NCT. Then wash hands and put on clean gloves and observe other appropriate infection control procedures. This will help reduce transmission of microorganisms. So after our hand washing, we can now don our clean gloves. Then, we have to provide for clients privacy, especially if the patient is in the ward with other patients beside you. This will help or will maintain our respect for clients' dignity. Then, we have now to detach our tube. So first, we have to disconnect the NGT from the suction apparatus if it is connected. But in this case, our NGT is not connected to any suction apparatus. Then we have to unclean the tube from the client's gown. So we have to get the tube from our client's gown to help facilitate easy removal of the tube. And then we have to remove the adhesive tape securing the tube to the nose. To effectively fold the NGT while rolling between the palms. So we have to remove our adhesive tape. We do not have to use alcohol to loosen the tape since alcohol might irritate the nose of our patient. Then we have to pinch the tube with a gloved hand. So we have to pinch it here. Pinching the tube prevents any contents inside the tube from draining into the client's throat. So while removing, you have to ask the patient to breathe deeply and hold his or her breath. This closes the glottis, thereby preventing aspiration of gastric contents accidentally. Sir, habang ginakuha ko ang tubo, pwede ka maginhawa dalong kag tunggan mo ang imong ginhawa. So while pinching, we have to quickly and smoothly withdraw the tube. This will prevent tissue trauma. Nawalan dalong sir, kag tubong. So, and place the tube into your waste receptacle or plastic bag. Placing the tube immediately into the bag prevents the transfer of microorganisms from the tube to other equipment or people. And then observe for intactness of the tube. Make sure that the tube is complete. So you have to check into the waste receptacle to examine whether the tube is intact or not. And you have to ensure clients' comfort so you can provide mouth or oral care if needed to prevent this will also promote comfort and prevent infection. So we can follow the protocol of the hospital if we can have a gargle with warm saline or with a use of mouthwash. Or if the patient is unable to tolerate mouthwash, we can use padded tongue depressor to provide oral care for our patients. So after providing oral care, you have to assist the client to blow nose as needed. So the excessive secretions may have accumulated in the nasal passages. So you can offer the patient tissue and ask the client to blow his nose. So sir, mag-blow ka sa nose mo sir, kaya basta may mga secretions pa nga nabigay sa inyong mga ilong. And then, clean the client's nose. Then dispose. Then we have to dispose equipment properly. So correct disposal prevents transmission of microorganisms. And we have to do our hand washing to promote infection control. And of course, do not forget to document relevant data. Documentation provides a record for future references. So you really have to document what time you have removed the NGP and to the patient after removing the NGP. So that ends our procedure, the removing